How's that? Yay, I did it.
Good job.
All right. Next, we're gonna just go over the draft agenda. We're gonna begin by welcoming you, which we already did. We'll do our roll call. We're gonna spend a lot of time talking about the impact of federal policy changes, which are quite significant and will affect all of the organizations that we're dealing with. And everybody here, I would imagine. I don't think any one of us is immune. We'll spend a little time talking about pending bills, several of which are germane to that issue. We'll try to get some work group updates in, and then the other thing that we really want to emphasize is that we're going to be meeting in May. We're going to really need to try to get a quorum, and I'm kind of hoping that everybody can show up face to face, make that as your 1-year Lenten resolution to make sure you're here on May 20th, 9 to 11. It'll be here. If we can have food, we'll have food, we'll have fun. But it's really important because we have a lot of business that needs to get done in terms of approving minutes, things like that, that really has to happen. So now that that's done, let's see who's here. So I'm just gonna call the roll. If you could just tell me your name. If you're here, just say here. If you're at home, just say where you are, and why you're not here, I guess, and who you represent. So we're gonna start out with Alexandra Sosnowski. Is Ali Saku here? Ali? Andy Hession. Ann Landry. Anna Thomas. Benjamin Hilliard.
I believe he is on his way, but maybe a little late due to traffic.
Okay, you can always add her in later, right?
Yes, I
Yeah.
can.
Beth Daniels. Bobby Bagley. Christine Brennan. I forgot to tell you, I'm David Nagel. I'm a house rep. I'm here. David Rochford. He's probably busy. I heard there's some stuff going on across the street. Deidre Daly.
Here, I
Yay.
am in New Ipswich and I just had work conflicts. Sorry about that.
Good job. It's all right. It's all right. You're here. That's all that matters. Ed Shinshala. You get to stay here. Jennifer Johnson. Joshua Meehan. Justin Romanello.
Here.
Yay.
Sorry, I'm late.
It's all right. You're here. Actually, you came right on time.
Perfect. I planned.
Jim McNamara. Lauren Pearson. Margaret Pritchard.
Here.
Yay. Sorry, I used to coach kids. I didn't say anything. I couldn't say other things. Martha McLeod / Judith Jones.
Here,
Is that Judith or Martha?
this is Judith.
Okay. The New Hampshire Alliance. Megan Hustler.
I'm here, Megan Heusler, Community Hospital Representative. I'm in Dover and I had a flat tire this morning.
Oh, no, we were just talking about that because I just had that happen. I'm sorry about that, but you're amazing that you're here.
I will also add that Lauren is here, but having trouble with audio.
Okay. We're going good. Melissa Martinez Adorno. Monica O'Clair.
Hi, everyone. I'm here, Critical Access Hospital rep, and I'm enjoying the snow and also have meeting conflicts.
Oh, wow, good for you. Enjoy this. And Morgan Harris.
Good morning, everyone. I'm here. I'm actually in my office in the insurance department. I have a 10:30 meeting, so I wasn't going to be able to drive back and forth, but I'm here virtually. Good morning, everyone.
Morning. Paula Mattis. Phil. Okay. Okay. I'm sorry if I'm going too fast. Phil Sutton.
I am here in the room.
Yay. He's the star of the show today. Holly Campion. Rebecca Bryant. Ruben Hampton.
Here, just scheduling conflict. I have to head over to that house session.
Suzanne, oh gosh, Bill Ausher, am I saying that right? Suzanne Prentice. Hi, buddy. Tori Jennison.
I am here online from the New Hampshire Public Health Association. I'm in Dover, New Hampshire with some sort of bug, and it's bad optics for the public health folk to
Good
to
girl.
come copy.
Good
Thank
girl.
you.
I have chicken soup on the way. Tricia is on.
I believe Tricia will also be joining a little late due to travel conflicts
We're doing good. Whitney Hammond, yes.
here.
Bill Palmer. Gonna yell at Bill later today, and then Daisy Pierce. That's it. And we do not have a quorum. All right, I've done my job. And then we want to announce any non-voting public members. If you're on or you're here, please just let us know who you are and if you represent somebody who you represent.
Scott Foster here with Health and Human Services, DPHS.
Bronwyn Barnett here with Health and Human Services, DPHS Cancer Program.
I'm sorry, it's the last.
Cancer Program.
And I'm Kristen Bonin here helping facilitate the meeting.
You have to announce yourself, Palmer, or no?
Sorry, Palmyra Santos, part of the facilitation team.
Anybody else?
Jim Monahan with the DuPont Group, and I'm part of the conversation this morning on Medicaid developments.
Hey, Jim, nice to see you, even if I'm not technically seeing you.
Great.
Christine Stoddard. I'm also part of the conversation on impacts. I represent Bi-State Primary Care Association and New Hampshire's Community Health Centers. Thank you.
Thank you.
And Jess Williams, New Hampshire Fiscal Policy Institute, just attending alongside Phil today.
You're getting all this, right? I don't need to write this
Yeah,
down. I don't know why I'm doing it. Anybody else? That was fun. All right, now I have to remind us that we are a bipartisan advisory group and our work is to identify how health and well-being can improve for all, I'm reading this, for all New Hampshire residents, so the health of all of those things for all New Hampshire residents. So we are a bipartisan group and that's important. Our big role, or one of our big roles, is to inform the legislature and the Department of Health and Human Services. We're sitting over there. If a policy may have a negative impact on the state health improvement plan. All right, how am I doing? So far, so good. All right. The next big thing that we want to do is I've heard that Medicaid and housing are an issue. And it's really important that we address those issues, and that's what we're going to do today. So we have a wonderful group of panelists here to help us through that process, and they're going to solve all of our problems today. Phil Sletton, and I'll let you guys introduce yourselves. Christine Stoddard and Jim Monahan kind of already did. I'll turn it over to Phil to start.
Sure. Great.
Well, and did Palmyra want to maybe make a couple of
Oh, yes.
comments about how we're doing
Yes.
questions in this session?
Yep, thank you. This is a large group and there may indeed be lots of questions. If you'll put them in the chat, I will coordinate them and either call upon you or present the questions at the end of the presentation. So just write them down when you think of them. And then for each of the presentations, and then at the end, we'll have the opportunity to answer other questions if they come up and or have our discussion. All right? All right, off to you, Phil.
Yeah, I just want to say a lot of us have been losing a lot of sleep lately, so this is really important. But really looking forward to having what you have to say.
Great. Well, thank you everyone for the opportunity to speak. I appreciate it. As those of you who have been on SHOT Shift for a while know, I mean, I still have my digital version of the letter I got from Jeffrey Myers in 2019, inviting me onto the SHOT Ship. So it's been an honor to be here. My name is Phil Sletton. I'm the research director at the New Hampshire Fiscal Policy Institute. We at NHFPI are a nonprofit, nonpartisan, independent policy research organization. We examine the state budget, state revenue, the state economy, and the economic security of Granite Staters. So particularly those of us with low and moderate incomes, and that expands to include, the well-being of Granite Staters a little bit more generally. Although, as the name implies, we do focus on fiscal policy. So I'm going to talk about a lot of budgets, budget numbers, and funding streams today. And that's going to lead into some of the discussion that I know Christine and Jim will be able to provide relative to what are some of the secondary and tertiary impacts of if these funding streams were to change. When I say secondary and tertiary, that's not importance, it's just what happens afterwards, right, if the funding were to change. So go to the next slide, please. So this is just a high-level view of the state budget. This is the entire current state budget. It is not all state spending, but it is the bulk of, the vast majority of New Hampshire's state operating spending flows through the state budget. And really the slice of the pie that I want to highlight for you is the federal fund slice. This is the blue slice is the largest on this pie. And think about it as roughly $1 in $3 that fund state spending in New Hampshire, state government spending, flow from the federal government. So this is a pretty wide variety of programs that are in this blue slice of the pie, but we'll talk about Medicaid in more detail. If we can go to the next slide, please. Just to give you a sense, that 1/3 is not particularly unusual either for New Hampshire. If you look at how our state budget is organized, that's been relatively consistent over, as you can see, going back to state fiscal year 2006. And New Hampshire is also not unique in this way that we are this reliant on federal funds. There are some states that are more extreme in terms of being more reliant or less reliant. Actually, a lot of that on the more reliant side especially has to do with their Medicaid match, because in some states it's a more significant program in terms of the federal state split. The federal government pays a larger share than it does in New Hampshire. But if you consider all those federal funds as a percentage of state budgets, then New Hampshire's a little bit on the lesser side, but basically close to the middle of the pack in terms of how reliant we are as a state government entity on federal funds. One thing you might be wondering is, wait, I thought a lot of federal money came in when there was, Medicaid expansion in 2014, and with the CARES Act, there was $1.25 billion in flexible funds that came in. With the American Rescue Plan Act, there was another nearly $1 billion that came in. Why doesn't that show up on this graph? Is that just those little variations? Well, those dollars are outside of the state budget, right? So those dollars aren't accounted for when you're looking at the pie chart that we saw on the last slide. The funding for Medicaid expansion for the Granite Advantage program, as we call it now, is entirely outside of the state budget in terms of where the numbers are recorded. And those one-time flexible funds from the CARES Act and ARPA, those were managed outside of the state budget process as well. The Joint Legislative Fiscal Committee and the Executive Council managed those funds as opposed to the entire legislature assigning them. For the most part, there was at least one, I think maybe two bills that did assign American Rescue Plan Act flexible funds. So the legislature had the authority to, but did not incorporate it into the state budget as a whole. I'm seeing a furrowed brow. Are there any questions on?
No,
Oh, okay,
just
all right.
listening.
Okay, I just wanted to make sure it wasn't,
I have no poker face.
Okay, fair enough.
No more.
Well, feel free, I should say, feel free to jump in with questions if anyone has them. I don't want anyone confused by material that's on a slide. So if you have a technical question, please feel free to stop me. But moving on, thank you. So this is where federal funds flow to in the state budget by department. So these are our state departments, and you can see there's a slice that is others that has 23 million there, so everything else is wrapped in there. But the bulk of federal funds, you can see, go to the Department of Health and Human Services, Transportation, Education, Environmental Services, and then you can see Safety, Energy, Military Affairs, and Veteran Services have significant components as well. That Health and Human Services slice, if it weren't for Medicaid, Health and Human Services would probably be smaller than Transportation and maybe Education on this graph, to give you a sense of how important Medicaid is in terms of the size of federal funds that are coming into the state and as a component of the Department of Health and Human Services budget. Next slide, please.
I have a quick question.
Yes, go ahead.
Regarding the Health and Human Services, if we're a sub-grantee of some of their funding, like, would that reflect in safeties or reflect in?
Yeah, so interagency transfers do show up in the state budget, and they are often deleted back at the end as other funds. So the federal funds landing in the state budget would show up in Health and Human Services. But if it's transferred as it falls into the other funds category, then that is backed out of the state budget totals. But here, this is just where the federal funds lands first. So my guess is, without knowing the exact program, my guess is that in the state budget's accounting, federal funds that are then repackaged and transferred to another agency wouldn't show up on this graph in their final destination. It would be where they land first. Yep, you're welcome.
And just to add, I think there were some folks online who couldn't hear the original question. To summarize, I think it was just saying essentially if one agency is a sort of receives funds as a sub-grantee from another agency, where does that get listed in this chart?
Thank you. And on the next slide, you can see what I mentioned Medicaid a couple times here. When we're talking about Medicaid, who is enrolled in Medicaid? And this is enrollment, and I want to give credit to Jess Williams, who's on this call. She made this graph. This is enrollment as of January 31st of this year. And you'll notice that nearly half, and it's actually about 48.5% if you incorporate children from some of the other slices of the pie here, nearly half enrollment in Medicaid is children. And granted advantage adults, so these are adults with incomes below 138% of the federal poverty guidelines, is about 1/3 of enrollment in total in Medicaid. But you can see children and adults with disabilities, children who are in foster care or formerly were in foster care, adopted, and adults with very low incomes. That's in the DHHS's reporting. That's all, those are a couple categories combined together. You can see that that's in that lighter orange, lighter blue slice, about 7%. Older adults with or without disabilities is that darker green, and then folks who are pregnant and have low incomes, that's in that 1% there as well. Remember, this is snapshot enrollment. Yes?
I'm just curious, because there is a bill about a work requirement coming up, and in terms of the granted state advantage program, what percentage of those people are actually working?
That's a great question. If we look at national data, then we know that about, I think it's 64 or 65% of enrollees who are in Medicaid who are between the ages of 19 and 64 are working, and I think the denominator there is folks who with or without a disability. So that's and the last data that I've seen for New Hampshire was the Kaiser Family Foundation published it in mid-2024. And I'll draw on my colleague Jessica Williams because she's seen these data more recently than I have, I think. So Jess, if I get anything wrong, please chime in. The data that was published in mid-2024, I believe, was from 2023, and it had estimated that in New Hampshire, 64% of Medicaid enrollees who were in that age bracket were working. So that age bracket is not just granted advantage enrollees. Again, if I'm remembering the denominator correctly. I can send around to the group that information afterwards as well. But it's the majority of Medicaid enrollees, again, at least those between 19 and 64, who are in the labor force in some form, part-time or full-time. And there were, the Kaiser Family Foundation's national level research did identify reasons that people weren't in the labor force, and it was typically they were in school, they were caring for someone else, so they had to do that full-time as opposed to working. Or they had some form of disability. Those were some of the commonly cited ones as well. Jess, did I miss anything that you want to chime in on? I'm putting her on the spot in case I'm missing something. Go ahead, Jess.
Yeah, sorry, I walked away for a minute, so I missed the first part of that. I believe you got everything though. I can drop that Kaiser Family Foundation resource into the chat as well.
Okay.
So people have the reference.
Okay, great. Thank you, Jess. And I see Tori put something in the chat.
Yes, she put, I believe, some additional information, and Whitney has a comment.
Yeah.
Do you have any models that talk about, so it's my understanding that even if somebody is employed, they're going to encounter bureaucratic difficulty in verifying employment. So of that percent that are in fact working, there will be a certain percent that just drop off because of the requirements. Do we have any idea what that?
So
in states that have the requirement?
Yeah, that's a great question. So I haven't refreshed it, but in 2019, we did an analysis of what have other states experienced or what have they studied with implementations of various types of work requirements and what would happen to enrollment. And in all of those cases, enrollment dropped, right? But it ranged from I think it was based on Minnesota, if you scaled it to, or, based on Montana and you scaled it to New Hampshire, then there'd be roughly 2,000 enrollees lost. Other studies, if you scaled it to New Hampshire, it was more like 35,000. When New Hampshire started implementing a Medicaid work requirement, there were, I believe, about 17,000 people who, before the work requirements implementation, sorry, if there are folks on camera, I shouldn't wave my hand in front of it. Before the work requirement implementation was paused, there were roughly 17,000 people who were at risk of losing coverage if it had been implemented. And that's because, in large part, they didn't have the paperwork. They didn't know, the state didn't know what their employment status was. And my understanding from the State Department of Health and Human Services, which I obviously don't want to speak for the whole department, but I have asked this question beforehand, is do we know how many people on Medicaid are working? And without new systems in place, that's not something that the state would be able to draw and give us a count saying, we know definitively that this income is from work, for example. They know the incomes, because that's important for eligibility, but they don't necessarily know where it's from in the state system, is my understanding. Great, thank you. Yeah, I just want to flag that if we're talking about enrollments, the total number of people as of the end of February who are enrolled in Medicaid statewide, it's a little under 187,000 people. That's a little over 13% of the state's population, and is significantly more than some of the other key assistance programs that the state has. So you can see those listed here. And for the sake of time, we'll move on. Oh, there we go. So I mentioned that Medicaid funding is, when it comes to federal funding, Medicaid is a really significant portion. Medicaid is the single largest program the state operates in dollar terms. So last fiscal year was about $2.5 billion in expenditures. That's federal and state funds. And when you think about the total state budget, and again, not all spending is in the state budget, but the total state budget being about $7.5 billion a year, right? We're talking about over $8 billion a year going to the next one. We're talking about a very significant portion of state expenditures flow through Medicaid in some form. If we count just federal funds, so only federal funds coming into the state for Medicaid, collect all that revenue into one source, and say that we're counting that as one revenue source. It is the single largest source of revenue the state had in fiscal year 2024. So it's larger than the business profits tax, which is the state tax revenue source, the state's largest tax revenue source. It's larger than gross revenue from the Liquor Commission or from the Lottery Commission. It's the single largest source of revenue was federal Medicaid. Now, there are several proposals under consideration at the federal level that would substantially change Medicaid funding to states. And this is not, what I have here as an analysis is not the full scope of those. There are some proposals that are being discussed that are either Medicaid work requirements or block granting certain components or changing what are permitted expenses. All of those, we don't really have enough detail yet. At least I haven't seen enough detail yet to be able to model for New Hampshire, if you will. But there are two proposals that are measurable and that we can model for New Hampshire. One is changing the Medicaid match rate minimum amount. So right now, the federal government has a Medicaid minimum match for states of 50%, meaning that at least 50% of all Medicaid expenditures, and it's higher in some other programs, at least 50% of Medicaid expenditures are paid for by the federal government. And that is a floor. Not all states are at 50%. There are some states that are in the 70s of percents because of their because of socioeconomic factors. Basically, what is your average income, right? What's the average per capita income in the state is not the only, it's not the only way the formula works, but it's a key part of the way the formula works. And that per capita income in New Hampshire is a relatively high income state. So we are at that minimum 50-50 along with 9 other states. If that floor were to be removed, which is one of the proposals, that would float us down to a 42% match, meaning the state would pay 58%, the federal government would pay 42%. If you were to model that for planned expenditures or expected expenditures in state fiscal year 2025, and these are point estimates from DHHS that I did the math for to say, all right, let's take it to 42%. What does it look like? That would be $194 million. In additional costs that the state would have to come up with to fund current Medicaid services. Now, that's the non-Granted Advantage part of the Medicaid program. The Granted Advantage program has a 90% match, meaning 90% of the dollars are paid for by the federal government. There was a proposal to make the Medicaid expansion match go to the base match rate for states, right? So it would go to 50% under current law, if just that were to change, or if both changed, it would go to 42%. And if it goes to 42%, you can see in the bottom half of the table, what happens if it changes to 80, 70, 60, 50, or the 42%. If you take that 42% and then you'll see that that's nearly $300 million that the state would have to pay to continue to fund Medicaid expansion at current service levels. Add that to the $194 million, and you get almost $500 million, $293 million that the state, $493 million that the state would have had to pay if these policies were both fully implemented in this fiscal year and Medicaid expenditures panned out in this fiscal year as expected by the DHHS. So that's, that's an additional, and there would be other pieces of statute that have to change because there is a trigger law that would trigger the end of the Medicaid expansion program if the federal match dropped below that 90%. So it's not all this would happen automatically, right? State policymakers would have to make changes to both statute and within DHHS, but the amount of money required to fund services at the level they currently are would be an additional $493 million. That was my densest slide, so if we move on to the next one.
That was scary.
Yep, here we go. If you want to learn a little bit more, the first link, the communications team at the New Hampshire Fiscal Policy Institute would love it if you all signed up for our newsletter and you could get these things in real time. But the second link that you see on here dives into more detail into those potential federal funding changes. And that table that you just saw on the last slide is again explained in detail there. There are a couple additional resources here as well. And if you go to the next slide, for those of you who don't want to type in nhfpi.org/subscribe, you can take that image and get there quickly with your portable computing device. And I really am looking forward to hearing from Christine and Jim. So thank you all for your time. I'm happy to, are we taking questions as a group at the end? Is that best?
Yeah, I think we're thinking, well, I'll let Palmyra speak to this. I think I know, but Palmyra's the best.
So any additional questions for Phil? This has been a lot and folks may have questions over time, a lot of information. Any reaction or questions at this point, or you can save them also for the discussion.
I have a question.
Go ahead.
If by statute as of right now, if the match for Granite State Advantage goes below 90%, the program ceases to exist and we save a ton of money, correct?
So the program ceases to exist within 180 days. What would happen is internally, the state would have to deliver notification to policymakers within 48 hours. They'd have to deliver notification to enrollees within 10 days, and the program would end in 180 days. The federal component of Medicaid expansion is 90% of the cost. So right now it's about $600 million a year program, and 90% of that's paid for by the federal government. So we would be talking about the non-federal share being on the order of $60 to $70 million that right now the state is paying for through a portion of insurance premium tax revenues, an assessment on insurers, the high-risk pool assessment. Some in recent years, it's required some liquor commission money to be a backstop as well. But last fiscal year, it wasn't required after the Medicaid unwind and disenrollment following the pandemic. And there's a little bit of Medicaid enhancement tax revenue that goes into it too.
So this is my hope, my cynicism, but if this all happens, then we've balanced our budget and a lot of people are miserable. Is that correct?
So the federal funds component, remember, it's outside of the state budget. So right now, the state budget conversations that are going on are generally around, usually around general funds, right? So the state is short on general funds, education trust funds, highway funds, and a little less so on the education trust fund side. But currently there aren't any general funds that go to Medicaid expansion, right? So when policymakers are, as they are this week and next week, deciding what's in the state budget and what's out, those are mostly conversations around general funds. And there aren't any general funds involved directly in Medicaid expansion, although indirectly through liquor commission funding, there could be, because there is a trade-off there. And I'm happy to get into that in more detail if folks want to know exactly how it's structured. I should say also the Alcohol Abuse Prevention Treatment Fund makes a transfer to the non-federal good share of Granted Advantage. But you may have heard, policymakers are looking for several $100 million in savings in the state budget relative to what the governor proposed. The $600 million a year that Grant Advantage cost doesn't count against any of that because it's not in the state budget.
Thank you.
Yep, you're welcome.
And if I could just comment, you put all this in writing in a blog. and
Yes.
That would be great if people had access.
Sure.
to it. It's wonderful.
Absolutely. I'm happy to share it in the chat.
So, are there any other questions for Phil right now? And if not, who's next?
Christine.
Christine? All right, you're up, Christine. Thank you.
Thank you. Good morning. My name is Christine Stoddard, and as I said, I work for Bi-State Primary Care Association. We're a nonprofit that's focused on advancing access to primary care and preventive services for all, with an emphasis on those most in need in New Hampshire and Vermont. We also have the great pleasure of representing New Hampshire's community health centers, the area health education centers, clinics for the uninsured in Vermont, networks, and different consortia, including the North Country Health Consortium. So today, New Hampshire's community health centers serve over 100,000 patients. They are located in medically underserved areas, which means that those communities have a difficult time accessing care, either because of a lack of primary care availability or geography issues. They are regulated by federal law. The state does not regulate community health centers in the way that it regulates the mental health centers because they were established by federal law. They are part of New Hampshire's safety net though. So if something negative happens to the community health centers, it affects our access to care as a state. So 36% of the health center's patients are commercially insured. 31% are insured by Medicaid, 19% are insured by Medicare, and 14% are uninsured. We have to remember that as great as the Affordable Care Act is, it doesn't mean that everyone now has insurance. There's a variety of reasons why people are uninsured. They might experience homelessness. They might not have lived in New Hampshire for 5 years. It's a very complicated issue. And I think it's also important to remember that every health center is very different. So if you look at Ed's Health Center, Ammonoosuc Community Health Services, Ed only has 4% of uninsured patients, according to the 2023 federal data. But if you look at Nashua, which is Lamprey Health Center, they have 29% of their patients are uninsured. There's also a health center in Nashua that serves predominantly people who are experiencing homelessness. Prior to the pandemic or prior to Medicaid expansion, that health center's patients were almost 100% uninsured. Now they are insured by Medicaid or another federal benefit, and they have a limited amount of uninsured patients. So it was basically the inverse thanks to the Affordable Care Act. Health centers use a wide variety of revenue to meet the needs of their communities, but over 70% of their revenue comes from federal and state grants, Medicare and Medicaid. So when you think about the changes that Phil was discussing, the health centers will be greatly impacted by any changes to Medicare, Medicaid, and the federal grants. A number of them receive grants from the state that are also actually funded by, as Whitney can tell you, federal funding. So any changes at the federal level will greatly affect the health center's ability to provide care to their patients. When we expanded Medicaid in 2014, we also created a substance use disorder benefit, right? We expanded that benefit to traditional Medicaid as well. And I'm sure you saw in the news the other day that Governor Ayotte said that in the last year alone, the New Hampshire's overdose deaths due to opioids decreased from by 35%, which outpaces the national rate of decline. It's not hyperbole to say that this is due to Medicaid expansion. Without Medicaid expansion, your community health centers could not provide substance use disorder treatment because they would not have the reimbursement to support that service line. When community health centers are faced with tough financial decisions, as Ed could share with you, they have to make hard choices. If they can get reimbursed for primary care services, but not SUD, which lines of service will they have to cut? The ones that they don't receive reimbursement for. So we have to think about these things when we're making these tough policy decisions. Do we want to continue to be able to address the opioid crisis in New Hampshire? Do we want to continue to address homelessness? The Medicaid program helps us do that. Of course, there's always room for improvement, right? The community health center's Medicaid reimbursement is actually an all-inclusive rate. It supports what we call enabling services. So if one of their patients has problems with transportation, for example, in Coos County Family Health Services is the only primary care provider in that entire service area. So Berlin, Gorham, Colebrook, it's just Coos County Family Health Services providing healthcare in that area. If one of their patients experiences transportation issues, they work with the patient to get them to their appointments, to get them into, if they need services at a hospital, if they need services at the facility, they work with them. Our health centers also are required to provide, by federal law, translation services. So if some of their patients, Amoskeag Health is a great example, they speak over 63 languages at their health center. If one of their patients can better access care in their native language, the health center works to find a translator to provide healthcare translation services rather than relying on a family member or someone who might not be a medical translator. But just because the health centers have 36% commercially insured patients, that doesn't equate to access to healthcare services and no uncompensated care burden for the health centers, because we know from studies that New Futures and the Healthcare Value Hub did that 71% of Granite Staters experienced at least one healthcare affordability burden in the last year. This includes the health center's commercially insured patients, right? So federal law also requires that community health centers provide what is called a sliding fee discount. So for those patients that live at or below 200% of the federal poverty level, and they cannot pay their co-pays to the health centers have to discount their healthcare services. And oftentimes, especially for under and uninsured patients, they cannot afford those co-pays, even with the discount, because $4 is too much for them to afford. So the health centers call that uncompensated care. In 2023 alone, the health centers, 10 of them, had $14.5 million in uncompensated care. This is a combination of uninsured patients. It's a combination of underinsured patients. And there is no mechanism at the state level to help the health centers address this. They write it off. They close sites. They make very tough decisions when their uncompensated care increases. The health centers do their best to mitigate these issues. Some of their staff actually pay what little they make to a benevolence fund to support access to healthcare services, to support access to pharmaceuticals that the health centers, that the patients need help affording. And I think we can't minimize the importance of Medicaid for the substance use disorder treatment network. Just using the community health centers as an example, since we expanded Medicaid and the SUD benefit was created, just those organizations have seen a 274% increase in SUD patients served. That's a 460% increase in SUD visits. If, for example, someone in Coas County or Amanusic service area needed healthcare services, they needed SUD services, they truly don't have an alternative place to go. So we need to think about the long-term impact when we make these policy decisions. The other issue that comes up when we change eligibility for Medicaid is what happens to the patients when they can't access care or they can't afford care. Yes, the community health centers have to treat everyone regardless of their ability to pay or insurance status. But that only applies to the services that they have control over, right? If they go to a non-community health center, that healthcare provider doesn't have to honor their sliding fee discount unless they have an agreement with the health center. They don't have to provide free or reduced care to services unless they're a hospital. So oftentimes patients will delay care or go without care. I'll never forget a story that one of Lamprey's medical directors told at one of our legislative events, I guess 10 years ago. There was a patient who had diabetes, who has diabetes, who was rationing her insulin because she could not afford the insulin before Medicaid expansion. She also reused the needles that she used for insulin. When she was able to access Medicaid expansion and her prescription medicine, she began being able to treat her diabetes, and it was in control and under the limits. She went to see her doctor at Lamprey, and he congratulated her for how well she was doing on her blood sugars. And as she was leaving, she asked the doctor to take a look at an abscess on her abdomen. She had reused the needles so many times because she could not afford them that the needles were breaking off in her abdomen and caused an abscess. This is what happens when people can't access care in a timely way. They delay care, they go to the emergency room, which is much more expensive, or they go without care. I think if you walk away with anything today, I hope that it's the reality that Medicaid supports so many people and so many organizations and our safety net system. If you look at just the community health centers in New Hampshire, they save the healthcare system 24%. The savings to the Medicaid program alone is over $68 million. The savings to New Hampshire's health system is almost $150 million. If we reduce programs that support the safety net network in New Hampshire, the savings is affected, access to care is affected, and the economy is affected. Health centers employ over 1,000 people, and they support a total of more or almost 2,000 jobs. Their total economic impact is $261 million. What happens if they go away? So I'm happy to answer any questions if you have them. I didn't mean to be the downer after Phil's positive presentation, but this is the reality that our safety net system is facing.
I just wanted to say your passion is obvious, and I really wanted to thank you for your presentation. That means a lot.
Thank you.
Do we have any questions now? Because I have a million, but I don't want to do that now. Go ahead, Ali.
Good morning, Christine, and thank you for your brilliant presentation. During your presentation, one of the many things that you said prevent people from accessing healthcare in general is 5 years living in New Hampshire. Is it New Hampshire or the United States?
I say New Hampshire, but you're right, it is the United States.
Okay.
It's the Medicaid program.
Appreciate it.
You're welcome.
I see Maggie has a hand up. I'm sorry.
No, you go ahead because I can't see.
Hi,
These don't
Maggie.
help that much.
Christine, I'm curious because I get a little jealous when the FQHCs are able to get data that collectively tells a story that we've struggled with on the community mental health side, like your savings to the state or your savings to the United States even. Are all
Yeah.
of the FQHCs on the same platform, and is data collection easy for you in terms of that?
So I should say, Maggie, FQHC is the same thing as Community Health Center. People use them interchangeably. So the federally qualified health centers in New Hampshire are your community health centers. Community health centers have to submit data to HRSA, which is their regulating body, and it's called Uniform Data System, right, Ed? That's the right.
Yes.
So unfortunately, the current administration took access to that data down. Thankfully, my colleagues at Bi-State downloaded it prior to it being removed from HRSA's website. That is where we get a lot of our data, Maggie. They are not all on the same platform, but every single community health center has to use UDS data. It's part of their grant requirements. The financial data that I quoted you, our health centers are also audited by the federal by every year. And they also are inspected by HRSA every 3 years. And that includes their financial audit. So this is how we get their data, because they're audited and because they're on the UDS. Our national association also works with an organization called Capital Link. I don't know, Maggie, if they work with behavioral health centers across the country, but it might be something to look into, and I'm happy to connect you with them, because that is how we understand the economic impact. Their employee data is also in UDS, as are the insurance statuses for their patients and the services they provide.
It is not easy data by any means, and
no.
The audit is called an Office of Management Budget Circular A-133. Anybody who receives over $500,000 in federal funds has to go through that. It is an unfunded mandate. You do a Medicare cost report, unfunded mandate. Federal Tort Claims Act, unfunded mandate. UDS is an unfunded mandate. So you start to see the administrative costs. I'm a regulatory minimalist. As long as patients don't die, I'm good, and our staff are safe. But clearly, we could use some regulatory reform, and I could get a group hug and a check in the mail. Nice. But so yeah, the UDS data are important data on a variety of levels. In the state of New Hampshire, most of the FQHCs, not all, are on the same electronic health record since 1996. It is transitioned to Athena, but it's still an SQL database that you can pull things out of that database relatively easily. Phil will appreciate comment delimited format, which means you can do a lot of interesting things with the data afterwards. But yeah, it's not easy. I feel bad for the community mental health centers. From a federal policy perspective, it is probably the most abysmal federal policy ever implemented in the United States when we deinstitutionalized places like Willowbrook, because nobody wanted those people in the neighborhood, even though they were family members, and we never funded community mental health the way we should. You can thank the Kennedy and Johnson administration for that. There's a special place for them in Dante's Inferno, I'm sure.
You are so subtle in your.
I'm a Gen Xer, not a boomer, so no love lost with that.
I've always heard I was subtle. I know, I always enjoy you. We're passing notes too, which is, I've done that since 5th grade, but anyways. Are there any other questions before we move on to Jim?
Yeah, can I ask a question? Sure. Yeah, we have the community mental health centers, but we also, the QHCs, they provide a lot of mental health services as well. Can you speak to how Medicaid rollbacks, whatever we're calling it, could affect those professionals in the mental health field?
Yes, so community health centers, every single one of them does provide some level of behavioral health services. They work well with the community mental health centers in their area for those patients that experience persistent mental illness. But they provide the community health centers provide a significant amount of behavioral health services, and they have really expanded access because Medicaid pays for telehealth visits. So if we decreased Medicaid reimbursement or changed the eligibility for Medicaid, the health centers would not be able to meet the needs of their patients at the same level they are now. I do have mental health data, but I didn't print it out for me, and I can send it to Palmyra if you'd like it. But we were able to expand behavioral health services because of Medicaid expansion, and it's just like the SUD benefit. Ed's Health Center also goes into schools. A lot of our health centers have school-based mental health clinics, and they've done amazing work with kids across the state to provide behavioral health services. And those children are on Medicaid. And if the governor's budget were to pass and the cost sharing were to pass, those families would now have premiums. And I can tell you, it is very hard for someone who makes $60,000 to afford a premium when they have 3 children at home who need to be fed, who need access to pharmacy and healthcare. So just cost sharing is also a significant barrier.
I have a question. Is viability and existence a potential problem here?
Yes. So because when the Medicaid system did what we call their Medicaid unwind, when they decreased eligibility because the public health emergency ended, many of their patients became uninsured. They didn't lose their patients, right? The need for healthcare doesn't change. What changed was their insurance status. And so if you look at Lamprey Healthcare, which serves Nashua, Raymond, and Newmarket, 1,000 of their patients lost health insurance. Lamprey still has to treat them. So that increases Lamprey's uncompensated care. When we continue to increase the health centers' uncompensated care due to policy changes, they have to make very tough decisions. One of our health centers recently decided to reduce the amount of MAT services that they provide in their service area because primary care receives a higher reimbursement. Another one of our health centers has their staff have taken pay cuts to accommodate for the losses that they're experiencing. Another health center has shut down sites in Manchester because of uncompensated care. So there are a number of things that happen when we make these policy decisions. And it's, you know, it's not just the patients, which are obviously the most important impact that we see, but health centers are businesses, right? So you're affecting New Hampshire's economy when these decisions are made.
When you look at the broader context, for instance, we're $11 million, 2.2 million of our federal dollars that comes from our grant. It has not seen any adjustment in a decade. That's an economic erosion of $750,000. 340B, we could have a whole weekend's worth conversation on the 340B drug pricing program due to unilateral questionable legal action of manufacturers and DBMs and the limit our ability to contract with whom we want, infringement on free trade. In a granite state, awkward, where we live free and die. That's a $650,000 economic erosion. So when we look at Medicaid, our estimates are another $500,000 impact, $250 in lost revenue, $250 in sliding fee scale. You know, the sliding fee scale that comes out of the grant that hasn't seen a change, that already has a $750,000 economic erosion. You will see economic Jenga. So if these patients don't come to us, they'll go to the ED. Now you're going to see the bad debt go up. And having lived through the Balanced Budget Act in an urban area and watching a 400-bed hospital that is now a vacant lot, one should have great pause and consideration for playing economic Jenga with our friends and family and neighbors' lives, if I can't appeal to your sense of humanity, which appears to be more difficult these days, even Milton Friedman would disagree with the economics that are being pursued. That's a pretty hard right conservative economist. I think he would disagree with the economics of this. It isn't even saving money ultimately. And none of these money is saying we'll come back to any of us. You know, so if you're going to save money in Medicaid in the state and the federal level, it's never coming back any grant is standard. It's going to go to 3 individuals. We know who they are.
So I just looked at the time. I think we need to move on to Jim, but
Yeah,
this was
thank you.
wonderful. Yeah, this was
Thank you.
absolutely wonderful. Thank you, Kristen. You're up, Jim.
Great, thanks. I'm glad to join you. So I was asked to talk today a bit about the advocacy and education that might be underway in New Hampshire to deal with the issues that we're talking about today. Just so you know, likely as I work through this, will present some of this through the lens of the folks I work with, which, includes the mental health centers. Christine talked a lot about the community health centers, but others as well. So let me start off by touching on a couple of, actually, Christine and I talked last night. We were worried that by the time I spoke, we'd be in a situation where everything has been said, but not everyone has said it. There are some important issues that I want to elevate that haven't been discussed yet today. So let's start off with some of the big challenges that I'm observing in this space. The first is that I think the executive branch of state government in New Hampshire appreciates that there's a lot of bad things on the horizon and in managing rolling dumpster fires, but the legislature has not yet embraced the fact that that there's a potential significant change coming, potentially coming with federal changes. For a lot of reasons, and it may be they're just dealing with the issues right in front of them now, which is the state budget. Another challenge from an advocacy perspective is that this is a complex issue, and we honestly don't know when or what will happen. And we're not exactly flying blind, but I want to talk a bit about a general understanding where things might be. So from a planning perspective, we can think it through. You're probably aware that several weeks ago, the U.S. House of Representatives voted to start the process of developing policies around these issues to address issues around paying for tax cuts. And so the U.S. House Energy and Commerce Committee was sent direction to find $880 billion over the next 10 years in savings, which if you take within their scope of responsibility, the biggest pieces there are Medicare, Social Security, and Medicaid. And the sense is that they will not be touching Social Security and Medicare, so that leaves Medicaid exposed. An $880 billion reduction would be about a 25% reduction in the amount of money that's federal money that's spent on the Medicaid program, which would be a pretty extreme reduction. The question that I keep asking to our partners that have federal lobbyists is, okay, well, when are they going to decide? The expectation is maybe in April, but ultimately they're not going to advance something out of committee until they think they have the votes on the House floor. Then once the House acts, when will the Senate act? Up until about 2 weeks ago, our sense was that the U.S. Senate would be dealing with these issues through reconciliation with 2 separate bills, and that they would do it under their normal order. And we might not see the Senate take any action until September in anticipation of the end of the federal fiscal year. Recent discussions have potentially accelerated that a bit, where there's an effort earlier in the process, perhaps with a new deadline of maybe Memorial Day, to get the House and the Senate together on when they would take steps around the big picture, but what we're talking about is Medicaid. Ultimately, the problem there as well is they don't want to advance it until they have the votes. So that opens the question of the what. Phil went through in some detail what the whats are. What I have been looking at is the risk exposure to some of the programs, so some of the proposals at the federal level, and how they might impact New Hampshire. And I put them into three categories. The first category that I'm paying much attention to is Medicaid expansion because of the 90% trigger. Then there's a series of mid-range things that the Congress could develop, which might impact the U.S. Their total. They might not go from 880 reduction. It may be in the 200, 250 million. There's a range of things we do there. And then there's a larger issue of massive change in what would happen. So within the context of the Medicaid expansion piece, both Phil and Christine have talked about this in some measure, I'm working with the community mental health centers and others to develop a better understanding of what the impacts of that might be. And Maggie will correct me if I'm wrong, but I think we've surveyed the centers in the Medicaid, the Granted Advantage population is probably about in the 4,000 individual range. Although one of the good things about those programs, people don't stay on it very long. They're not on it for the rest of their life. They typically are on it for about 9 months. So that number fluctuates. But if you look at the impact it would have on the community mental health centers if a significant portion of the Granted Advantage population were to lose their coverage, it's probably, I don't want to exaggerate too much, but probably not sustainable for the community mental health centers to continue to operate the way they do. Because as you know, under state law, the community mental health centers are required to care for people regardless of their ability to pay. And as Christine identified, the redetermination process stranded thousands of folks who had been covered under Medicaid without coverage for weeks or months at a time. And had there not been some opera funds to bail out the community mental health centers, I'm not sure if many of them would have survived. All of them had operating losses as a consequence of that. And so it really accelerated or elevated the issues around uncompensated care, which would become a pretty dramatic impact if the Granted Advantage coverage went away, but the patients did not. The other probably huge issue, as Christine and others have identified, is what the impact would be on the SUD environment. Prior to Medicaid expansion and Granted Advantage, there was no significant reimbursement for SUD treatment, and an industry really built up around it. Without Granted Advantage, those programs would collapse, and I think it's the numbers are, I'm going to get this wrong, but it's 10 to 18,000 individuals who take advantage of SUD coverage through Medicaid today that would lose their coverage. And I think we'd fall right back into some of the horrors that we experienced prior to addressing those issues. So that's among the risk profile. That's one that folks are paying close attention to. The timing of that is really interesting because, as many observe here, the New Hampshire law says that if the FMAP drops below 90% within 6 months, the program goes away. What's interesting about that is it says not when we know it will happen, but actually when it happens. So we're watching quite closely what the timelines might be that come out of the congressional actions. Will it make changes to FMAP to drop that 90% on day one, like October 2nd of this year? Probably not. Will there be, there's more likely it will be some ramp up over time so that the states can prepare for reductions or changes in the FMAP. And I think in large measure, that's why the Ayotte administration has not advanced anything in the current budget to deal with that issue. She's observed that it's hypotheticals for now. So I don't know. So that's something we're watching closely. If the FMAP changes, when does it change? And how much time will we have to prepare for that? So that's the first category of risk. The next category of risk I'm looking at is the nickel and dime stuff. When I say nickel and dime, it's hundreds of millions of dollars. But let's say the reduction is not 880, but it's 200 or $250 billion. There, I think we'd see things like work requirements, lifetime caps, elimination of provider taxes, and other changes which could all add up. And these are all things that are foundational to the financial underpinnings of the Medicaid system in New Hampshire. So if the ProShare program went away, the county nursing homes would collapse. If DISH went away, the hospitals would lose $250 million a year in uncompensated care that they receive. These are all things that they're probably not big enough to blow up the entire system, and we just manage through a series of dumpster fires to figure out how we're gonna to manage those. All of these are designed to reduce the federal spend and the consequences downshift. And that's what we should probably be looking at potentially over the next 3 to 5 years, that the federal government will downshift costs to the states will downshift costs to providers. Providers like the mental health centers are stuck because they can't downshift to poor, sick people that can't provide it. And so there'll be a long, ugly process of trying to manage continual downshifts or reductions in programs. The third category of risks or preparation I'm looking at is what if they go big? What if they go above $250 billion? What if they try to reduce the Medicaid spend by $880 billion? That's so big, I think it would require a significant overhaul to the entire Medicaid delivery system in New Hampshire. The AOT administration has already semi-publicly floated the idea if they had to deal with that, they would try to convert the system to a block grant system. That's a whole, Dave, that's a whole other webinar to talk about what that might be. But I don't think we should, while we certainly have identified a lot of the harms in this conversation today, I think that we should also prepare ourselves for the fact that not everything that we're seeing on the horizon will happen, but I don't think we'll be in a position where nothing will occur. In adopting the attitude of it's better to have things done with us than have things done to us is something that it will be where we should be over the next 6, 12, 18 months as we prepare for what could be major changes to the Medicaid program. So what are we doing about that from the government affairs, advocacy community? Many of you people are involved in it. We have informally set up what we're referring to as the Medicaid Search and Rescue Team. We have advocates from the provider community as well as healthcare advocates who meet on Thursday mornings to have a very candid set of conversations. We don't include public officials because we don't want to necessarily be stifled by that or show off for them. So it's a good, healthy conversation where we bring in a national perspective that helps us understand what might be coming down the tracks and when. These are New Hampshire-based provider groups that have national trade associations that help us with that. We are thus trying to stay informed at federal level about how things might impact us so we can prepare for it. And then in phase 1 of the public advocacy, there's a communications subcommittee of that group, which is standing up some basic education about the value of the Medicaid program in New Hampshire. As I observed at the beginning of my presentation, I don't think the legislature has a full enough appreciation for the value of the program, let alone a sense of urgency about what it might mean both for the state budget and for individuals if there were significant changes made. That group's effort, as I said, is ad hoc. We may be in a position by summer to have a better sense of what might be coming down the federal path, where more substantial advocacy and communications will be developed, will be elevated on that. But it's meetings like this where kind of the shared sense of concern is elevated, which is going to help dictate what the advocacy space might be. So I'm looking at my notes, I'm looking for a way to end this on a positive note, and I'm not sure that we'll get there. Other than say, one of the things we have experienced, whether it be through COVID or the opera or budget is that there is a great group of healthcare advocates who always work together to ensure that the rising tide lifts all boats. I expect that that will continue to be the case, whether it be this group or our ad hoc groups. There's just an army of really smart people that both understand how the systems work, look for solutions, and above all else, advocate on behalf of the, the tens of thousands of people that rely on public health care to live their daily lives. Let me just say something that I've struggled to do here is to try to help both myself and folks in the state government understand that we can all be a little detached and look at dollars and cents in the long haul, but I can imagine if you're somebody who suffers with a mental illness or a family with children or adults in the DD system who's barely hold it together with Medicaid as a piece of what they manage on a day-to-day basis, the stress of uncertainty that's being created now is awful. And that's wherever possible. I think we need to help public officials understand that, that's a population that is most directly affected by this, but they're not at the tables hashing out the details. So anyway, that's my attempt of ending on a positive note. But
thanks, Jim. That's very helpful in a really sad way, but it's very helpful. Go ahead.
Yeah, so I just want to give a shout out to the community mental health centers. I used to work in one way back 30 years ago. They are the capstone of the whole mental health system. And a lot of people don't realize that they're in schools. There's very few external or private practice folks that will take Medicaid. You can't get a psychiatrist that takes Medicaid in the state, or it'll take you probably a year. And they also are a training ground for most of our workforce, so the unlicensed folks that have to go 2 years to get their hours. So we're ruining our workforce in the future as well. So I think we have to realize how important those community mental health centers are and how hard they work. But it extends into all areas of our lives.
I have a comment that I was wondering, Jim, if you could, or any one of you can comment on, but there's two different ways of looking at the world. There's the 30,000 foot view and there's the ground view. And my observation being in the legislature now for a little over 2 years is that currently the 30,000 foot view is dominating. And I think, as you say, people are at that view are totally oblivious to the effects that they're going to have on the system. Whereas there's a significant number of people in the legislature that work at the ground view that see the potential damage coming. How can we work with your group and other groups to inform the legislature of how important these issues are and the ramifications of their actions? Maybe that would be a positive way to end this discussion.
Well, I'll lead off on that, but I'll only say I don't necessarily have all the answers. But what we saw when we had to change the legislature's mind on the values of Medicaid expansion was wherever we were able to translate the 30,000 view to how does it impact my community, and then the storytelling, which was significant. The storybooks were put together, videos. So it's that bottom up for many members of the legislature that, they may have been elected thinking these government programs are awful. My job is to come here and dismantle these things. When they appreciated the impacts on the people that are their neighbors or work for small businesses in their communities, we were able to, at least for the time we needed to, convince the legislature that expanding Medicaid made a lot of sense, that they were able to put aside their political bias and look at it through the lens of their community. So take that and multiply it by 100 when it comes to the work that's before us on major changes to Medicaid.
In DHHS, Representative Nagel can provide Medicaid data by town. We can provide you the payer mix by health center. If that's something that's of interest to you, happy to send that link to you.
That would be awesome, and then probably every legislator needs to hear that. And, you know, letters by the thousands do make a difference, I think. So
Thank
I
you.
think mobilizing communities to advocate is really important. Any question, Ali?
Thank you, Dave. Thank you, Jim. During your conversation, I loved how you said things. You said that it's always good to have things done with us than things done to us. And I think the inclusive mindset that you use here with us helped me to understand what this whole mission of your work is. What do you think would be the biggest challenges and opportunities that this organization is facing? I did hear you saying that you know many of the legislators might not understand the full work or the full picture of the work you guys are doing. But also, as you mentioned during your presentation, what do you think, after the challenges and opportunities, what do you think will be more beneficial for us here sitting to share with our community at large and to mobilize them when necessary?
Well, I think, you know, as I said before, the more people have an appreciation for the value of the Medicaid program now, the more they're going to be willing to defend those underlying values. Then this is a part that's going to be hard for all of us, I think. And maybe I'm wrong about this. I hope I am. But right now, we're busy building the barricades to prevent change or prevent bad things from happening. There's going to be a point in time where there's going to have to be an acceptance that the current program is going to need to change. And for all of us, that's going to be a very, very hard transition where we're going to say things have to be done differently because of the, you know, like it or not, so-called reforms are coming down at the federal level. So, you know, it's important to be on the barricades now. But I'm trying to remember my French Revolutionary history. If that did that lead to good things or bad things? But there will be you know, it's important to be there now, but understand that it's going to have to transition beyond that. I have accepted the fact that right now there's a lot of work being done to defend an imperfect system because we don't know what the alternatives are. And frankly, those proposing changes don't know the consequences, but that's something to be ready for.
I would try to be very diplomatic in my statement, but I mean, this is what EMS has been facing for decades nationally, and so yeah, I would say that, you know, we tend to look at things from that 30,000-foot view far too much and not look at the ground level. So, I mean, very diplomatic.
That is taken very nicely.
Yeah.
I've heard the other side too.
It's safer not to hold back.
The left hand side, yeah. Now that my son is an EMT, I fully appreciate what you just said. Palmyra, did you want to? I know we don't have a huge amount of time left, but did you want to share the chat questions or?
Folks have been great of jumping up, and I've been talking to people individually, so I think we're all set there.
Okay,
I think just
great.
close any other additional questions and then we can move on. The panel has just been fabulous.
Yes, you've been awesome.
Yes.
This is really scary and informative and helpful all at the same time. So you need to know what your enemy is before you decide how to mobilize. So that, I don't know if enemy is the right word, but I just used it, so it is. But thank you.
Thank you for having us.
That was really great. And I'd love to talk with each one of you at some point, although I'm staring right at Phil right now.
Yeah, sure.
All right, we should move on then. And kind of related to all of that, we have 10 minutes to talk about all the bills that are before us right now and get people's thoughts, feedback on these, because some of these bills are very pertinent to what we just discussed. So we didn't even get into housing, which is another huge issue facing us. So, but anyways, what I'd like to do is just go through these by categories. You can see on the slide in front of you a series of bills, and does anybody have any thoughts, comments about the 3 housing bills, or the, I'm sorry, 4 housing bills that are listed there? And feel free to jump in, and if everybody's quiet, I've got plenty to talk about. So does anybody have anything that they want to contribute that they know that we should know?
I'm glad Dee has her hand up, so I was gonna call her out. So.
Just give her hand up, because I can't see, so
Yeah,
somebody
she's got her
else.
hand up.
Yeah, I'm sorry, Dee.
No problem, Dee Daly. I'm actually the New Hampshire Municipal Association liaison to this group. And I think that there are some interesting, I think a lot of these bills, while they're very well intended, my background in small town planning venues has been that some of these are probably well intended, they're just cutting a little too hard. And that there's some richness and goodness in there, but I think they don't really address, and they may under address a few things, right? So going from, I understand that there are towns that have 50-acre lot minimums, definitely probably needs to change, right? But if we now go down to minimum lot sizes that are at 66,000 square feet, but we don't back that up with well data in places where, well and septic, and make sure that it fits the community, I think that's where we're going to struggle. There's been a couple of bills that are worded better than others where they say, hey, if you can't, your town has to defend why it can't do some of these things. That's better than you must do these things. And so I think there's goodness and richness, but I think I'd like to see each of these find the better middle ground that'll make these even stronger and more acceptable to various communities. So I think that's probably the shortest way I can give you feedback on these. And even things like accessory dwelling units, mandating them by right. We have one of the most liberal ADUs in our community, and it's still by special exception just to make sure we don't wind up with steel and glass in the middle of farm country or, something like that. So I think there are some things that still could be refined on these, and they're worth the refinement. If we're going to be this prescriptive, then it should be at least a refined prescription and not an axe, and maybe a little bit more scalpely. Sorry, not the best words, but you get the general intent there.
No, folks, what you're saying, the devil's in the details, and the details aren't right there yet. Is that fair?
Yes, very much so. It's worth the effort to find that happy medium if we're gonna start to be more prescriptive.
I appreciate it, because when I looked through each one of these bills, I saw potential in each one of them, but I wasn't sure. I'm really glad for that feedback.
Well, and the other thing that's really interesting is that I know cognitively that supply is going to get us out of this. And I don't doubt that we have to do something. One of the things that's interesting is our community is saying none of these solutions is actually getting at the cost of housing. They're trying to hold our feet to the fire for zoning changes that we're trying to make. And it's tough. I mean, it's just tough. So I don't think I'm telling anybody anything they don't know.
Yep. But there's still hope, because they've only passed one house. There's another house to go. Do you have any hope there?
I do. I think that it's, well, unfortunately, I hate it for some of the people in the second house, because they're going to face a lot more pressure, and that's going to put more onus on them to try to find the right answers. And I just don't know that the resources are there with everything that's going on. I think the legislators are probably going to have to say what is really important right now and really start to focus their efforts on what's noise and where do they really need to put their effort? So, and I'm happy to help. I think there's tons of people that are happy to help. I think there's just, how do we even help more? So anyways.
Thanks, Steve.
I'm sorry. What'd you say?
I said, thanks, Steve. I was gonna call her out anyway.
Oh, okay. Is there any other comments from, and the other thing I do have to ask Palmyra and Kristen is, we only have 2 minutes left.
Yes, so Palmyra, I'll leave it to you, but I think we may.
Well, I think that we promised folks that we would be done at 10:30. So what we could say, and we keep not having the update from the wonderful work groups. So I don't know if there'll be a sigh of relief there or if they're
We did last time.
Yeah. So anyhow, I think that questions or additional information about any of these bills, if they could reach out, and then we'll communicate to the whole group. How does that sound, Dave?
That's perfect. I mean, you know, the notes are beautiful. So we can, are those AI generated or are those like humanly generated?
The minutes that we send out,
Yeah.
they start off AI, but then the
I
AI
was
gets a
gonna
lot
say,
wrong,
those
so
are
I
incredible.
Yeah, it takes a lot of work after the AI. Actually, we should send out the AI because they're really funny.
Yeah, I was gonna say, we just started using them and I don't like them, but if you do what you want, in my committee, I just do it myself.
It's nice to have Kristen to be able to make them readable.
Yes, she's awesome. Both of you are awesome. I did want to stress though, our next meeting is May 20th and try really hard to be there in person so that we can actually get to see each other just one time a year. That's what we're asking for. And then we all get to know who we are. I'll do my best to see that we get something to eat for it. If we can, we'll mess this room up as much as we can. But that was like very helpful. I thought scary, but informative and very helpful. And Phil and Christine and Jim, the other two may not be there anymore, but thank you so much. And we'll look forward to seeing you in May.
One thing to amend that I said earlier, Whitney had asked about Medicaid work requirement, the disenrollments and the disenrollment figures. I had said, I think 2 to 35 was the range, it's actually 2 to 23. I dropped the link in the chat. So I was waiting for her to come back to make that correction.
Well, she, in her deputy director role now, this is kind of what happens.
Right,
It's
yes,
like, with all this information that Jim is talking about that's coming down, there's always a gathering of the minds.
One of the things I would always remember, and we need to emphasize, a lot of these programs have multiplier effects. The dollars spent here saves dollars down there, and I think people, when you're just focused on the here and now and not the future, that creates really poor planning, poor thinking, but unfortunately it's pervasive. And I think the more we emphasize the dollars saved, like we just went through that with our county delegation on restorative or diversion programs and how much money they save down the road. And it's like, oh, you're speaking to whatever, fortunately we got it saved, but that arguments would save the day. So anyways. Unless anybody has anything else, I don't know if we need a motion to adjourn, but I always like saying that. So if anybody wants to make a motion, if you don't, that's fine, but I don't think we're that formal.
Dave, you ask, I will make a motion.
All right, second it, all in favor, or say aye. I always wanted to.
Members of the public abstain.
What?
Members of the public abstain.
Yeah, you can abstain if you want.
Technically, we can't clear out the forum, right?
You're right.
You can never leave.
Good point.
You can never.
Oh, you're right, good point.
Temporary suspension.
Oh, you're not party record.
Sorry.
Ruined my day.
Well, thank you, Dave.
Thanks, that was very good.
Thanks, everyone.
Kristen and
I'm
Palmyra
curious
for
though,
putting
Dave,
that.
to hear what, because you said you have so many